Hi, good morning, everybody. Welcome to another virtual morning report where we come together and share cases and learn from each other. My name is John. I'm a general internal medicine doctor and one of the Clinical Problem Solvers Academy members for those who haven't met me yet. And I'll be co-discussing a case with Ravi again today. And I'm happy to we have Ethan and Eugene helping us out with our teaching points and our scribing. And we have the privilege of a first-time case presenter, Samantha. So maybe Samantha, you unmute and tell us a bit about yourself, and then Ethan and Eugene, say hi too.
Good morning, everyone. Thank you so much for having me. I am Samantha or Sam. I'm a fourth year medical student up in Maine, and I'm very excited to be presenting this case today. I love this case very much, so I'm looking forward to getting started.
Absolutely wonderful. Very excited to have you here, Samantha, and especially a first-time presenter. Apart from Maine and lobsters, what is it that you like up there in Maine to do?
Oh, what's not to like? If you like the outdoors, there is no better place. You have mountains, you have sandy beaches, rocky coast, and desert all within an hour's drive of each other. So come to Maine. It's the best place in the world, literally the way life should be. So,
Absolutely wonderful. Yeah.
amazing community.
Uh, great place to go hiking and also enjoy nature. So wonderful. Thank you. And you tell us what do you aspire to do after medical school?
After medical school, I'm working right now on my application applying into emergency medicine, hoping to do a mix of hopefully some rural critical access hospital work and some teaching.
Absolutely wonderful. So lots of luck in the following year in the match, and I think you're doing wonderful.
Thank you so much.
And we have for teaching points, Eugene. You want to unmute Eugene and say hi? How are things?
Yeah, hello everyone. My name is Eugene. I'm a physician from Ghana. Yeah, things are going on well. We just have some nursing striking, so we're kind of taking double shifts. So just that is what is going on so far. Yeah, and I'll
Absolutely,
be teaching part. Sorry.
absolutely wonderful. Thank you, Eugene. And then we have the wonderful Ethan. How are you? How are things in Taiwan, Ethan?
I'm doing great. Yeah, a busy working day on radiology. I'm in radiology department right now, but yeah, very happy to join the session and excited to learn from Samantha and the discussion.
Okay, whenever you're ready, Samantha, with the first aliquot, take it away.
All right, we'll start off with our chief concern. This is a 32-year-old female with no past medical history, and she presented to urgent care for workers' comp with a left wrist injury. And urgent care noted her blood pressure to be 229 over 134 and sent her to the emergency department.
Wow. All right. So we have incidental, high blood pressure, but in a 32-year-old, seemingly healthy woman coming in for a workers' comp appointment. So when we hear this, like some of my first reflex thoughts are, just make sure this is, it's probably unlike it's probably just make sure it's an accurate measurement. I always, whenever I see something that strikes me as, extremely abnormal, want to make sure it's real. But and then really our first priority with somebody with really high blood pressure is to determine, is it causing any consequences in the body? Is it a hypertensive emergency? So going to do a focused history and exam to try to find out more context about, are there any clues about end organ damage? I presume that she's, doesn't have any, personal history of high blood pressure, at least that she knows about. Most 32-year-old healthy people aren't checking their blood pressure at home with a cuff. But if this is real, it's not your run-of-the-mill essential hypertension and somebody like this young with a blood pressure this high. So, presuming it's real, I'm also thinking end organ damage, and I'm thinking through possible secondary causes of hypertension that I'll be prioritizing those when I, get the rest of my history. Ravi, what would you layer on?
Yeah, I think that's a wonderful start. It's interesting as we have new interns starting in July and they get that call from the floor, blood pressure of 200, and the first reflex is always to like, let me administer something. And the favorite antihypertensive to administer to a blood pressure like this is hydralazine, which is usually we have to tell a lot of our interns, do not use this medication due to the wild fluctuations in blood pressure that you get. So this is interesting. I mean, this young person has come for one complaint or one issue, which is totally unrelated to this blood pressure. So she has no idea. She has a blood pressure of 221 over 132. This blood pressure has probably been there for quite a while. It's not suddenly when you have a sudden upswing in blood pressure to 200, you will have effects. The effects could be cognitive effects, headache, visual disturbance. And a blood pressure this high can do an insane amount of damage within the body, can perpetuate vascular injury, cardiac injury, over a long period of time, kidney injuries, cardiac ramifications. It's just the blood pressure like this, a body will suffer major, major consequences. So when we're looking at somebody like this, number one, there's no sign of emergency. Like you said, end organ damage, although you have to do a head-to-toe evaluation, look in the eye, also then get labs to see if there's any kidney injury or anything like that that's been bubbling under the surface. But the patient's not coming in saying, I have headaches and I have visual disturbance, I have cognitive dysfunction, could I have a thunderclap headache or something like that? There's nothing there at all. But I'm very concerned because you let this fester and the downstream consequences can be very expensive for the patient with lots of different chronic complications. So we don't want this person to become dependent on the medical system with kidney disease, long-term kidney disease, cardiac disease, and so on. But it can also become severely debilitating in this patient. So they're not able at 32 years of age to function and contribute to society. So this is one where I really start getting serious and I really do want to figure out what's going on. And also, do I need to treat the patient? If, like, John, do you want to talk about, like, asymptomatic, what do we do? What do you do with an asymptomatic? A lot of the literature says, like, we see these patients come to the emergency room. Should we admit them? Not long ago, like 10 years ago, we used to admit these patients, right? But what's the current practice, you would say?
Yeah, I'd say like if they're really like asymptomatic, they don't necessarily require admission to hospital. So this thing can be like started on antihypertensive, titrated as an outpatient. Sometimes that call about is there end organ damage becomes messy, and especially most of the people I take care of are older with lots of chronic conditions, and a lot of times at the same time they may have something else going on. There's like a little bit of renal dysfunction. Is that related to their blood pressure? I don't know. So sometimes it's tough to tease out, and we end up admitting because we're not certain. But I love how you highlighted the kind of avoiding the hydralazine reflex when you get called about these really high blood pressures. Because the first reflex should be, is there something something reversible, that could be causing this blood pressure? Is this person in a lot of pain? Are they heaving and vomiting? Are they withdrawing from alcohol or opioids? Is there something I can fix that's causing it? Any secondary causes? But thinking through the end organ damage, as we already talked about. But yeah, hydralazine, it's so variable in how much it affects people. Some people will drop a little bit. Some people will drop. I've seen like get the push and they drop disproportionately. 60 to 80 millimeters of mercury and get reflex tachycardia and can precipitate a stroke if somebody's had blood pressure really high for a long time and you suddenly drop them. You have risk of acute kidney injury. You have risk of stroke. So it's not a benign thing to do. And you talked about the scary things that happen with high blood pressure. It's a risk for ASCVD, like coronary artery disease, and stroke. It's a risk for chronic kidney disease, for eye problems, these things. But these bad things that happen from high blood pressure take a long time to happen, actually. There was a very unethical study from like the 1960s where they took men with wildly uncontrolled blood pressures in the ranges of this patient in that case. And they randomized them to two one group got 2 antihypertensives and the other got placebo. And the people with the placebo, naturally bad things happened to them, but they looked at the time is when it did. It was like this happened, like, this was like several months later. I forget the exact, average time, but these like scary things happened, it wasn't, in time. So I think that's probably enough ranting about blood pressure and hydralazine for now. Maybe I'll turn the mic back over to Sam to give us some more context.
All right, love it so far. This next one's a pretty hefty aliquot. I'll just warn you up front, there's a lot of information. I'll try and go through it slowly. So this patient first injured her wrist a few days ago. She's been treating it with ibuprofen and Aleve every 8 hours, about 3 or 4 times per week. She went to the urgent care, got this really high blood pressure reading. They drew some labs, which did not come back, but they called her and told her they were not normal and she needed to go get checked out. Unfortunately, due to a recent storm and power outage, this is Maine, we don't have access to any of their records, so we don't know which labs were abnormal. We just know some of them are. For a little, further history, this patient has not seen a doctor since she was 18 years old. She does say there's a blood pressure cuff at her work and she has checked it before and it's been high, but she's not sure how long that's been going on. But for the last 18 months or so, she has been having worsening headaches, which she's describing as bilateral, located behind her eyes. They're episodic, they're pulsatile, and then they've been increasing in frequency from about 1 per month up to a few times per week, and now she's having several of them daily. They're associated with photophobia, phonophobia, nausea, lightheadedness, and these headaches last anywhere from 20 minutes to about 2 hours. And she has woken up with headaches before that were so severe that she actually noted there were scratches around her eyes when she woke up as if she was trying to claw them out in her sleep. Those are her own words. And these headaches have not responded to any treatment she has tried. She does say she has been feeling sort of generally off over this same time period, which is about 18 months. She's been having for the last 6 months worsening varicose veins in her legs, nosebleeds that are difficult to stop, and she does have a new, over the last few days, subconjunctival hemorrhage in her right eye, and she's been having intermittent palpitations. She does have a light history of tobacco use, less than 5 pack years, does not use any alcohol, and no other recreational drug use. For some social history, she works in a bakery at the local grocery store. She is not sexually active and denies the possibility of pregnancy. She takes no medications, has no allergies to medications, has never been pregnant, and has never had any surgeries. She does say her grandfather and her uncle both have high blood pressure, and she knows that there is some cardiac disease in the family, but she's not exactly sure who. That's the end of that aliquot.
Well, very well presented, Samantha. Now you've really opened the floodgates. So we were kind of hinting at associated features with headache. And now you mentioned some very scary features. So we have high blood pressure, then this headache, and we were talking about downstream consequences or sequela of blood pressure. So I'm trying in my mind at this point, yes, obviously this we sort of have to run in a dual track approach to this. Number one, now with these headaches, and these headaches, are they life-threatening or are they primary and secondary? So when you have certain features of a headache, change in the headache, increasing features, pulsatile, and now not responding, I guess those can be some of those could borderline on alarm features or signals. And then with the photophobia, that also is concerning. Nausea, vomiting could be associated as you have increasing intracranial pressure. And it looks like this has been going for some time. The wrist injury is something that brought her in, but now we have unmasked this blood pressure association. And with these annoying symptoms, she's really not gone to maybe gone to get medical advice or sought medical attention for them, sort of brushed them off as like, okay, it's a migraine and so on. But what's concerning is it's getting worse and unresponsive to treatment. But this pulsatile retroorbital, it's hinting on maybe something vascular. And there are certain features that we do look for. If we ask the question, how does blood pressure affect the eye? There's certain features that you may see in the eye. You may get papilledema is one of them. One of the other features could be, I guess, hemorrhages can also develop if you are able to get a good evaluation of the eye as well. I think visual disturbance, blurring of vision can also occur as well in that case. And there's some other features that are escaping me, but definitely that is concerning for me, especially with this blurring of vision. John, anything else? There are a couple other things. I'll leave them for you to discuss.
Yeah. So a lot of like for this aliquot of history, first, it confirms what we were thinking, that this high blood pressure has probably been going on for a long time. And multiple features that do make us worry about this person having consequences of their high blood pressure. The headache, kind of the first, we always think about, is this a consequence of high blood pressure and in turn high intracranial pressure, or other vascular consequences of the headache in the changes in vision. Sure, you can also have high blood pressure as a consequence of a migraine headache. Ask yourself the chicken or the egg question. But the fact that it's unresponsive to treatment, and that's always kind of, you come back to that. You wouldn't the migraine will kind of see how you respond to treatment. But more and more worried about consequences of the blood pressure, the more history we get. We heard about things like the epistaxis, which bleeding from the mucosal surfaces could be related to the increased capillary pressure as a consequence of the high blood pressure. Perhaps same with the varicose veins. We're seeing kind of perhaps a pressure overload phenomena. So with this, the epistaxis, we're like, is that a consequence of the blood pressure, or is that another part of the fingerprint of a systemic disease, of which the high blood pressure is a part of it? That's the other thing that I'm thinking about here at this point in the story, before we get our exam and our labs. That'll hopefully help us, get more of a clue to that. But this stage, like, worth brainstorming the potential, secondary causes of markedly elevated blood pressure. You have your kidney disease, like renovascular hypertension, endocrine causes, got vascular causes like coarctation of the aorta, lots of drug-induced causes. But it doesn't sound like from the social or the medical history that they're presuming there's not any medications, supplements that could be on board. Or another just common, this would be far out of proportion for this, but common things being common, untreated obstructive sleep apnea. So but those are some of my reflex thoughts here. So I think when I'm doing my exam, some people have highlighted in the chat, want to do a good neuro exam. If you have the ability to get a good look at the back of the eye with a fundoscopic exam, will be important. Cardiac. So yeah, I think I'm ready to take it away.
Just jumping in there about, so yeah, those two issues. One is this varicose veins, which is interesting. There's no, Samantha, no edema of the peripheral extremities?
Nope.
So varicosities is interesting. I mean, these could be due to, one cause could be obesity. The other is varicose veins is secondary to the valves in the veins becoming dysfunctional, maybe due to chronic stasis, maybe chronic pressure. Obesity is one cause of that. And post-thrombotic syndrome is also one cause of that as well. And chronic long-standing right-sided hypertension with increased lower extremity hydrostatic pressure within those vessels. So no edema though, maybe not at that juncture. Now the epistaxis is interesting. When you relate high blood pressure and epistaxis, if you go down the microangiopathic hemolytic anemia, the non-immune category, the non-TMA, you can get because of high blood pressure. What happens with the high blood pressure, you get significant shearing along the vessel wall and the RBCs can lyse. Can it also cause this bleeding? I'm trying to wonder. Could blood pressure also be a downstream effect of a TMA process like TTP-HUS, which it certainly can be? So labs will be crucial at this point. We have a high blood pressure. Labs will also be very helpful to see if we are in the domain of a thrombotic microangiopathic hemolytic anemia. But we don't have any signs or clues of anemia. So there's no pale subconjunctival. Well, we don't have the exam yet, but that would be a signal there as well. And then also look for any other signs where the patient couldn't be having anemia. The other thing would be hyperbilirubinemia, indirect from hemolysis. That also could be a signal as well. But yeah, this non-immune mediated hemolytic anemia from blood pressure is definitely something of interest to me. Back to you, Samantha.
Awesome. So for a physical exam, repeat blood pressure does show 213/113. So I love the thought of confirming that it's real, and it was in fact correct. Heart rate is 115. Her temperature was 98.3 Fahrenheit. Respirations were 16. She's saturating 98% on room air, and she's got a BMI of 29. She's generally well appearing. When you do her head and neck exam, you do note the right-sided subconjunctival hemorrhage, and she's got bilateral facial redness with scattered telangiectasias on both cheeks. We did not actually do a fundoscopic exam, but I love that thought as well. Her neck exam shows no JVD and no carotid artery bruits. Her cardiac exam discloses regular tachycardia, but no murmurs, rubs, or gallops. Her lungs are clear to auscultation bilaterally with no increased work of breathing. Her abdomen is completely benign, and there is no abdominal bruit. Her costovertebral angles are not tender to percussion. Her neurologic exam shows her to be alert and oriented with no focal deficits and normal reflexes. Her extremity exam does show popliteal varicose veins on the right side and no edema. And her psychiatric and mental status, she's appearing quite anxious, but her thought process is linear, judgment is intact, and behavior is normal.
Interesting. I think from the exam, some of the things catching my attention is like the facial plethora and the scattered telangiectasia. And I was feeling back, like we were brainstorming about the varicose veins and a younger person who's not obese. Just kind of like, is there some kind of underlying connective tissue or vascular process in the background? When I hear telangiectasias, like what could be associated with this finding and uncontrolled hypertension? Bring up like a scleroderma, possibly with blood pressure consequences. Did Osler-Weber-Rendu or hereditary hemorrhagic telangiectasias have association with systemic hypertension as well? But some reassuring things. The fact there's not like obvious neurological deficits is reassuring, that we're not dealing with some stroke or severe vascular consequences of the blood pressure. So yeah, I think like the main thing, the exam is kind of raising my antenna for a possible underlying connective tissue, like possibility of scleroderma. What do you think of any other hypotheses you're raising with the exam, Ravi?
Yeah, I think you're right on the same track that I'm on, in that the telangiectasias. Now I'm trying to weigh facial telangiectasias. Are they significant? Are they something enough that we can pivot to a potential diagnosis and then order all the expensive antibodies and the autoimmune workup panel for such a condition? Now, just for a teaching purpose, I'm going to use a mnemonic. I'll add it in the chat. They use the telangiectasia mnemonic. The T is what John just mentioned. The HHT-E is estrogen, so you will see it with pregnancy. Samantha already said pregnancy test was, I think it was negative, or mentioned that. L, liver disease. So in cirrhosis, we do see spider angiomata. A is ataxia, telangiectasia. And so when we look through dermatology and we describe basal cell carcinoma, you tend to have telangiectasias with that as well. The G, CREST syndrome, it's a genetic syndrome. John just mentioned the autoimmune workup. Inflammatory, you could just have benign states like rosacea, or you could have lupus. C, corticosteroids use on the face could actually induce telangiectasias. T would be trauma from sun. So if you're out in the sun quite a bit or radiation exposure, you can see telangiectasias. A, actinic damage. S, systemic sclerosis. I is iatrogenic. So any you ask if anybody underwent any what do you call it, dermatology treatment with laser therapy, and A is AV malformation. So if I go through that, yes, John, I'm interested in autoimmune phenomena, and autoimmune phenomena within a young person. There's certain conditions where you could have high blood pressure. One would be scleroderma renal crisis, right? And in that complex, what do we have? It could be a young person. They love to test this on shelf and USMLE step 2, 1. What is the treatment? So the ACE inhibitors in this case. And then you have high blood pressure, you have somebody with scleroderma, and you have high blood pressure, and you also have a microangiopathic hemolytic anemia. So that comes to mind, although we don't have features. Samantha didn't mention the scleroderma or crest-like features that you usually have with such a syndrome. But something to think about when trying to walk through the potential causes of something like this. Anything else comes to mind, John? I'll put the mnemonic in the chat for people to copy down then.
Oh, yeah, that's cool. Thanks for sharing that, Robbie. I guess like with these things highlighting them, there's not any obvious, signs of heart failure, along with the lack of neurological deficits. And thinking about the scleroderma, question, and something I'd be looking up live is like, how can you have renal and blood pressure consequences without how often does that take place without some of the other characteristic features we would be looking for? And I don't know the answer to that on the spot, so I'm still keeping it open as a hypothesis. And yeah, I think I'm ready to hear the labs and the next aliquot of information.
Yeah, the moment you've been waiting for. I've got some labs and imaging for you. So her white blood cells were 6.4, hemoglobin 12.5, hematocrit of 39, and platelets 216. For her metabolic panel, we've got a sodium of 142, potassium of 4.6, creatinine 4.81, BUN is 52, chloride is 108, her bicarb is 20, anion gap of 14, a glucose 93, and calcium 9.4, magnesium 2.4. Her urinalysis shows a specific gravity of 1.013. There's no leukocyte esterase or nitrates. She's got a pH of 6. No glucose or ketones in the urine. Notable for 300 protein and 250 red blood cells. So the reflex urine sediment did not show any casts. They did show 50 to 100 red blood cells with some dysmorphic red blood cells, 10 to 50 white blood cells, and no epithelial cells. A random protein urine was 264 with a random urine creatinine of 83.9 and that urine protein to creatinine ratio of 2.96. The other initial labs that we got, she was negative for HIV and hepatitis. She had a pretty normal looking iron study, normal B12 and folate, and a normal INR. Pregnancy test was negative and urine toxicology was negative. Her EKG showed a heart rate of 106, but no other abnormalities. And a retroperitoneal ultrasound showed a right kidney measuring 9.6 centimeters, and a left kidney measuring 10.8 centimeters, and there was one benign cyst on the right kidney with no cortical thinning, no renal calculus, no perinephric fluid, and no hydronephrosis.
Absolutely wonderful presentation so far, Samantha. This is such an interesting case, very educational. I mean, look where we started with this patient coming in with this wrist injury and blood pressure, and what do we do with blood pressure? Then it just opened up with so many associated signs and symptoms. But Jack, what I like to do is, oh, John, sorry, we should have some fun and get people involved with this great case. And it's about 12:30-ish. Why don't we do breakout rooms and send people off to discuss and think, and that way participate in this discussion? So we'll stop for a moment. Okay, and John, we're back, I think. People are making their way back. And so anybody that was in a breakout room want to unmute and share any thoughts? We can hear from maybe another person. Oh, Alina mentioned Suesh Dahal from Nepal has some great thoughts. Are you able to unmute? Are you in a place to unmute? Maybe share your thoughts?
Hello there, I'm Suyesh Dahal, I'm from Nepal. So yeah, we had some pretty interesting discussion regarding this case. And we are thinking along the lines that it could be some sort of a vascular process going on with all the telangiectasias as well as the varicose veins in a young patient such as this. And there's also some sort of kidney involvement. The kidney has also been involved by this vascular process, it seems. So yeah, I think the kidney is the underlying factor behind hypertension, I think. So that's what we're discussing. Yeah.
Absolutely wonderful. Yeah, I just love that thought. The kidney, we talked earlier on, the blood pressure can cause kidney disease, and the kidney disease can actually aggravate the blood pressure as well. So kidney is one of the centers for blood pressure regulation. If your blood pressure is elevated, you tend to have an increase in atrial stretch and ANP, which causes diuresis. In this case, you're not able to have that effect with a patient like this, so with kidney disease. So the blood pressure may be a cry for help from the kidney, and it's not the blood pressure due to other causes like pheochromocytoma, renal artery stenosis, and so on. So maybe the answer lies in the kidney, and these kidney parameters that Samantha so wonderfully presented actually could be a clue to something that's going on. My friend Anne-Marie is there. Are you able to unmute? Are you have any thoughts as well?
Yeah, I can unmute. I missed the first part of the case, but I definitely agree that, the center of gravity most likely is in the kidney. It's kind of a muddy history with also the NSAID use, and so I think it's kind of interesting about trying to figure out like what's the primary thing driving this. But definitely it seems like there's some sort of vascular footprint, but I'm curious if the vascular footprint is like the primary thing or a secondary thing. And so I think trying to figure out like, is this some sort of like vasculopathy or a vasculitis or like a fibromuscular dysplasia or some sort of like genetic thing like HHT, or is there some sort of like secondary tumor or genetic thing driving it, like a pheochromocytoma that could be associated with something like von Hippel-Lindau, as was mentioned, or is there some sort of like endocrine cause at play as well with the facial edema? So I'm excited, I think kind of getting more imaging to look for vascular abnormalities, and then also kind of structural causes and everything will be helpful. So as well as working up secondary hypertension. So I'm excited to hear more.
Absolutely wonderful. Yeah, I think that's great what you mentioned. It shed some light on could there be something else behind all of this as well. And vascular, like the previous Suasha does mention about vascular conditions, and Anne-Marie's mentioned inflammation of the vessels. Could this be a vasculitis? That pretty much that is pretty high up on our potential hypotheses here. John, I'll bring you back in. What do you think at this point with the UA and then also the chemistry? What are you thinking currently?
Yeah, so I like what AMK highlighted. There was like the tension point we're working off of was this or is a lot of these things we're seeing consequences of the high blood pressure, or is the blood pressure part of the fingerprint of perhaps of a systemic or a kidney disease? And if I need to make a yes at this point, and you take the urine findings with the blood and the protein and the dysmorphic red cells, and I'm prioritizing more kidney disease, specifically concerned for like a glomerulonephritis causing like the renal dysfunction and the uncontrolled hypertension is kind of my leading theory, but also keeping on the list the possibility of the blood pressure. If the blood pressure were causing a lot of like we were talking about the epistaxis earlier, if we were seeing like malignant hypertension with endothelial dysfunction, we're not seeing signs of anemia or thrombocytopenia or the endothelial dysfunction contributing to some of those things. But I'm shifting to think about causes of glomerulonephritis in particular, and those can be immune complex mediated, things like lupus nephritis, infection related, glomerulonephritis, POSI immune, the ANCA associated, and also things like the glomerular basement membrane antibodies, and you see with the pulmonary renal syndromes. We're not seeing a pulmonary fingerprint at this point. So thinking about the different buckets of glomerulonephritis, the complement levels can be helpful, because if you have an immune complex mediated, usually you will have suppressed complement, with the exception of IgA nephropathy. But the complement levels would be helpful. I think in sending some serologic testing for certain common causes of glomerulonephritis, not unreasonable at this point, because you want to make sure you have to worry: does this patient have a rapidly progressive glomerulonephritis that needs urgent treatment? Is one of the questions you want to make sure you answer quickly when you're taking care of this patient. So I like, Himun just dropped some labs in the chat that I think are talking about checking the complement levels, ANA, double-stranded DNA, the ANCA associated antibodies, and AMK highlighted about like we were looking at the renal ultrasound, also looking with the Doppler to assess blood flow, and it's an imperfect study, but looking for like things like fibromuscular dysplasia too while we're doing this first pass workup. And I know it's not part of the diagnostic reasoning, but part of the real life management to this patient. You see something like this, you're going to be working closely together with your nephrologists early on in the case taken care of, because you want to make sure you get it right with incident. Does this patient possibly have a RP, rapidly progressive GN that needs pulse dose steroids early on? So yeah, I listed a lot of things. Probably amongst those, anything you're prioritizing, what would be higher up in your list? Anything I miss?
Oh no, I'll just echo the wonderful things you said. The chat is just ripe with so many pearls. GN is probably what we're going to really be interested in. We'll probably make progress in this case by doing all the evaluations. I love the bit about the complement. I have a few of my students on here for the shelf exam. That really can help you decipher which one of the GNs, what John had just mentioned, very, very important, especially with lupus. So that will help you at least to get to the heart of the matter. And I think I'll swing the mic back to Samantha for some more labs with attention, particularly on all the what's in the chat for GN.
And maybe like somebody look this up for us live too. I mentioned like a lot of these diagnoses causing GN, but at least I'm not aware of like an association with these physical exam findings with the telangiectasias and the facial redness. Like can some folks look up associations between these telangiectasia conditions and glomerulonephritis and share what you find out. Yeah.
The chat was interesting. They're already saying lupus.
All right. Yeah, I love all this discussion. Yeah, at this point in the case, the urine sediment findings with the proteinuria, hematuria, and dysmorphic RBCs did also we sort of focused on glomerulonephritis a little after that and the causes. So the labs that we got after that point, her ANA with anti-double-stranded DNA, ANCA, and anti-glomerular basement membrane, those are negative. Urine, so her UPEP, SPEP, normal. Kappa lambda light chains were also normal. Her complement, her C3 was 122, which is normal, and her C4 was 44.4, which is very slightly elevated. And at this point, we were talking to the patient about kidney disease, and we were concerned about some sort of kidney disease. And then asked her a few like more focused questions, and she remembers, oh, I've had blood in my urine before after I've been sick. And then that's the end of this aliquot. And then the final aliquot will reveal the diagnosis.
Yeah, interesting. So a lot of the preliminary labs, maybe it is not immune complex. There definitely is kidney issues. Blood she's had in the kidney, from the kidney or urine, is also very concerning. So now do we go through, is this inflammation of the kidney or hematuria can be from anywhere other than the kidney? The urinary tract has many other levels, could be the urethra, ureter, gallbladder. Could there be malignancy? At this stage, unlikely, but this is quite concerning. But we do have a few other labs that we would at least order in this case for working up GN. The HSP at this age, HSP, IgA associated vasculitis is interesting. You have rash. I haven't heard of arthralgia. I haven't heard of abdominal pain, but that would be something that you would be concerned about. You do have association with leukocytoclastic vasculitis in this case. ANA was unremarkable in this case. So usually look for 1 to 80, but even more higher, maybe 1 to 320 in this case, but we don't have any abnormality there. And particularly C3, C4, when you have an active exacerbation of lupus, the complements do decrease. Anything else comes to mind, John, at this point?
Yeah, I think like that pattern of having blood in the urine after you're sick, presuming it's glomerular, if we make the presumption it's glomerular bleeding, then it does certainly raises the more weight to the theory of IgA nephropathy, even though we don't have a slam dunk text, all the textbook features of it. And I'd like is there an association between IgA nephropathy and the findings on her face? So you mentioned like the leukocytoclastic vasculitis, but I'm not sure if doesn't seem like exactly what they're describing on her exam. So I'd have to be looking that up live, but that'd probably be becoming my leading theory at this point, given the pattern and the first pass testing that we've done. When the complement levels are normal or high, you're prioritizing your posse immune causes or IgA nephropathy. And she's really not giving me vibes of like GPA or HPA. So kind of coming also to some process, that pattern of the bleeding when she's sick and some process of elimination with normal complementemic GN is making me kind of favor IgA nephropathy. It's my leading diagnosis. And I think I'd be advocating for tissue to get confirmation of this too. Is my next step to make progress.
Yeah. John, you mentioned about this patient again. You highlighted something that kind of escaped me there, but in this aliquot infection related GN is of interest. But what you mentioned earlier, complement is normal. Samantha mentioned complement isn't low. You always have to wonder, could the complement, you could potentially get testing where the complement is in a downturn and it hasn't decreased. So the patient has hematuria post being sick. Could it be infection-related GN? ASO and DNase titers will be relevant in this case, but now I'm kind of thinking about it, maybe not. But if the complement was low, this definitely would be in the running for possible cause of this. But yeah, I wonder about IgA vasculitis. We did earlier with the the help of others, thinking about vascular disorders, disease of the vessels, which is vasculitis, inflammation, and the kidneys inflamed, then I do wonder about IgA vasculitis being maybe a possibility.
And
Back to
besides,
you.
like,
Yeah, go ahead.
oh yeah, it's like IgA. And it's like, have we, and we don't really have the classic finding, we brought up scleroderma earlier as well. And like whether that, there, I think there's, if I remember right, there's some association with like a GN with scleroderma too. So it'd be something definitely question to be working together with the nephrologist to see. But I think like to help us have more certainty, I definitely would be advocating for tissue and just going back and doing another careful skin exam, because a lot of these things that we don't see right away on the first pass, they escape our eyes unless you're specifically honed in looking for them. So just go back, re-examine the skin, talk with the nephrologist, advocate for getting some tissue to help us with some clarity. So I say like leading with IgA, but the hypothesis of scleroderma is still on my mind too, actually.
Back to you, Samantha.
All right. So the outcome of this case, we did get a kidney biopsy, which showed advanced sclerosing IgA nephropathy, with some moderate to severe arteriosclerosis that appeared hypertensive in nature. She did have diffuse global glomerulosclerosis affecting about 80% of glomeruli, and some tubular atrophy. And there was a lot of interstitial inflammation as well. So the final pathology read was that this was end-stage renal disease due to sclerosing IgA nephropathy. And you're totally right that there was a little bit of chicken and egg going on here. This IgA caused this kidney disease that led to hypertension that led to further kidney damage was sort of the working theory. And throughout admission, we were able to lower her blood pressure. We didn't want to drop it too quickly because of the chronic nature of the hypertension. We didn't want to then cause her to have a stroke. But we were able to discharge her on oral antihypertensives, and her urine output remained appropriate. Unfortunately, 3 months later, she did have to initiate hemodialysis. She's on peritoneal dialysis at home, and she's now awaiting transplant. And just to give a little satisfaction to this telangiectasias that I'm hearing so much about, we ended up deciding it was rosacea.
The rosacea was in that mnemonic that I had mentioned. So
yeah, it's a little bit of a red herring, because we were all on the team kind of thinking of different causes. My thought was lupus. We were kind of placing our bets. I was betting lupus because of the facial redness. My senior resident thought it would be ANCA because of the nosebleeds. We kind of all had our own theory, but it ended up being the IgA.
wow. Samantha, I'm amazed. This is your first case and you just knocked it out of the ballpark. Tremendous presentation and so educational. We were able to talk about so many things. And this is, I could clearly see you in an emergency room, seeing a patient with a high blood pressure and then taking it from there, and then seeing the kidney disease and so on. So this is very much up your alley once you start residency. John, any reflections on this case? I just had a great time.
Yeah, wonderful case. And I love like the some of the twists and turns along the way. That that red herring, I just kept it in my pocket this whole time. I wouldn't let go of it until the very end. But yeah, fantastic case and a very well told story.
I think the one thing, Samantha, in retrospect now, when you said episodic hematuria, that is actually a association with a IgA nephropathy. So I think you kind of if I didn't really think about it, but then I'm like, wait a minute, it is part of the illness script. So that, and then you get ill, you get a URI, and then develop this IgA vasculitis. So she was sick and then probably developed this after. I was thinking about infectious related GN, but the complement was low. But IgA vasculitis also has this association as well. So something to think about when reading over these phenomena later tonight. Thank you, Samantha. Again, really appreciate you putting this case together. Absolutely smashing job. And please come back again, bring some other cases. We'd love to see you back here again. And over to Eugene for teaching points.
Yeah, so this was a case of a young female that presented to the ER with incidental high blood pressures. And the first thing to do to approach an incidental high blood pressure is to make sure that it's accurate. This patient also had left wrist pain, so we're wondering if the pain could be contributory. And one important thing is that you don't have to start with medications as your first reflex when you have an incidental high BP. Then the next thing is that you want to consider, is there any systemic condition that is leading to this high blood pressure, or this is just an acutely high blood pressure? So you want to look at the previous symptoms or the symptoms that the patient is currently having. Some areas that such acute high blood pressure, so organs that it can be affected, includes the brain, the kidney, the heart, and you could have cognitive symptoms. You could have headaches, which could be recurrent. And then the next thing is that we looked at the various symptoms that this patient came with. The patient came with pulsatile headaches, had retroorbital pain, which was bilateral, and we thought that that could be of that together with a pulsatile headache hinted at vascular cause. And then we looked at the papilloedema, which raised concerns for a long-standing high blood pressure, especially with associated blurring of vision. And then the epistaxis, that could be as a result of increased vascular pressures, and all could be related with high blood pressure. Then we looked at the varicose veins. These varicose veins could be as a result of obesity, it could be as a result of chronic right-sided hypertension, but we were thinking about the fact that it could also be as a result of increased, dysfunction of the valves and increased pressure stores and these valves and backflow of blood. Other conditions that can actually cause high blood pressure in this young patient could be coarctation of aorta, untreated or obstructive sleep apnea, CKDs, TMAs. And so we're now looking at examination findings and then the labs. The examination findings gave us some plethora, some telangiectasia, and that became the herring in the room, which in that we started thinking about, could this be lupus? So we're looking at which labs will point us to lupus. So we did the ANA, anti-dsDNA, but realized this patient was possibly immune. And so we went on with the biopsy. One thing that also was a pivotal point was the fact that this patient had episodic blood in the urine, and which is a key point to note in people with IgA nephropathy. And eventually the biopsy revealed that also revealed some kind of sclerosis, which was from a long-standing hypertension. And that is the end of the case. Very exciting case, and very happy to have been a part of it. Thank you.
Thank you, Eugene. Wonderful catch of all the major points there. I really appreciate you chiming in with all these wonderful points. Thank you again, Samantha. Please come back, bring some more cases. This was absolutely wonderful. I definitely learned a lot. And thank you, John, for coming on today and co-discussing. Any final words, John, before we say goodbye?
Yeah, just echo, great case, great storytelling, and please come back and share some more. Thanks everybody so much for joining today, and I will see you all next time.
All right, take care, everybody. Happy Tuesday. Bye.
Thanks, everyone. Have a good day.
Thank you, Samantha. Bye.